I have the great fortune of introducing Stephanie Barnes from Duke University, who has had the unenviable task of trying to add organization to chaos, that is advanced heart failure and mechanical circulatory support at Duke, where I was up until recently. So Stephanie will be talking to us about when to wean and when to bridge.
This is a lot of people.
Yeah.
Wow, this is impressive.
It is impressive.
I have to say, hats off to all the speakers. You've done a really nice job putting everything together. I look forward to spending the next 10 minutes talking to you about when to wean, not how to wean, but when to wean and when to bridge temporary MCS. Specifically thinking more about our percutaneous devices and discussing some of the clinical tools that maybe, can be, should be available to you as nurses or advanced practice providers to accomplish this task. The specific bridging strategies that we'll talk about will be specific to cardiac transplantation and durable VADs. So again, a lot to pack into 10 minutes, so buckle up, but also look forward to having some dynamic Q&A at the end. So I don't have any disclosures related to this talk. So I want you to stop and I want you to think about the team in your institution or the team that you work with. Are you the team that is on a team on the right, clearly collaborative, discussing patient plans? They are a little close to the elevator, so I'm a little worried that they're going to scoot out soon, but they're clearly collaborating. Is that your team? And if so, you should be proud of that team. Or are you a member of the team on the left? They're clearly disengaged, they're not talking, they're burned out. And on this team, perhaps there's a single decision maker on the team who's driving the care and not using the expertise of the multidisciplinary team. In the leadership world, we would say there are opportunities to improve collaboration. In the perfect world, we would all be members of the team that's on the left, right? But the reality is that that's not always the case. So I hope over the course of the next 10 minutes that we can talk, and we've heard a little bit about the importance of collaborative multidisciplinary teams and the approach to identify shock, to escalate temporary mechanical circulatory support, but the multidisciplinary team are also very important in de-escalation of MCS. By way of background, as we've already talked about, this is a bit of a data-free zone, but some things that we do know or do not know is there's no single validated weaning score that exists for use. There are some recent wean and bridge protocols that have been published in the literature. Most recently, we talked about the American Heart Association scientific statement that was published and presented to the American Heart Association. Does give some nice, at least, ideas about where you can use protocols. And also hats off to I don't know if there's anyone in here from Inova, but you've published some really nice protocols as well recently. Since 2018, there has been an increase in temporary mechanical circulatory support use due to the change in heart transplant allocation, and particularly utilization of temporary MCS as a bridge to transplant. And lastly, adverse outcomes have been reported in patients bridged from VA ECMO to transplant and durable VAD. Now, there are multiple considerations that you should be thinking about when discussing de-escalation of temporary MCS. And first, these discussions really start, or should start, at the time of implant. Appropriateness for wean, bridging, and explant occur throughout the days that follow insertion and should be part of the discussion during the day, during formal rounds, but even at 2 a.m. when you're running into clinical issues with the patient. Second is the patient's clinical scenario. What is the original need for temporary mechanical circulatory support in the first place? And it's important that you, as a nurse or advanced practice provider, are empowered to understand what the original reason was for temporary MCS being implanted and whether you've had to escalate temporary MCS since that time. Patients with acute decompensated heart failure, as we talked about earlier, are more likely to require MCS for longer term or for a bridge. But there may be considerations about patients' response to therapy, and we're going to talk about that in some of the coming slides. Lastly is that bridge. Where are we going? You should be asking yourself, if wean is not successful, what is our exit strategy? And are we, in this institution, able to provide the care that the patient needs to be able to get across that bridge? Now, one of the things that we'll hear throughout the weekend is the conceptualization and really to operationalize a hub and spoke model of cardiogenic shock care. And while I'm not here to talk to you about that, that's a really important component of discussing weaning or de-escalation of therapy, so that we're doing this in a situation and keeping in mind the roles of the multidisciplinary team members that can help get the patient what they need. So here we are, we have a patient who is actively on temporary mechanical circulatory support. Now what? We can't just sit here. Our days, we're not just gonna put our feet up, but what do we do? So let's talk about some of the monitoring considerations with de-escalation. So as mentioned earlier, there was, I will say, even though it was data-free, a very nice scientific statement that came out that was presented in the American Heart Association about patient monitoring during escalation and de-escalation. And I have to say that, as you heard earlier, the components of escalation really are the same considerations that you should keep in mind when de-escalating or looking at wean. So let's take a look at these further, and again, just have this here for you for reference more than anything. There are hemodynamic, echocardiographic and imaging, laboratory and physical examination considerations when monitoring patients' response to temporary mechanical circulatory support. There is, I'd be interested in hearing the debates about continuous PA pressure monitoring in patients who are on temporary MCS, but clinical parameters should be continuously evaluated throughout the weaning process, both to confirm hemodynamic stability and inform the need for additional meds. When assessing hemodynamics, your MAP goal is over 65, RA less than 10 to 15, a wedge pressure goal of less than 18, a pulse pressure between 20 and 30, or greater than 20 and 30, cardiac power greater than 0.6 watts, cardiac index over 2.2, and a POPI greater than 1 to 1.85. Now I say this, but each patient is very different and individualized. So an individualized approach to hemodynamic assessment and continuous monitoring of hemodynamic profiles during the wean process is very helpful. From an echocardiographic and imaging perspective, I really enjoyed the talk earlier about point-of-care ultrasound, because I do not live in a location where our advanced practice providers are credentialed to be able to do point-of-care ultrasound. I think we in this room need to push that forward and really advocate for that. But if you are using echocardiographic data, you want to look at both biventricular function. LV and RV size. Is your LV or RV getting larger as you're attempting to wean? What's your ejection fraction? Your left ventricular ejection fraction ideally will be improving, or at least will be over to 20 to 5%. Curious to hear what Dr. Katz thinks about trying to wean patients who have an EF of 10% while they're on maximal medical therapy as well. Want to take a look at the right ventricle as well, making sure that your RV is not severely reduced, because do we need to consider temporizing on temporary right-sided with a temporary right-sided device. We also want to look at the valves. Worsening valvular insufficiency as we are attempting to wean can lead us into the direction of maybe thinking twice about doing that, or at least being aware of it. And lastly is cardiac monitoring. Any ventricular arrhythmia that occurred during the time that the patient was in shock should be closely monitored. The goal is that the patient would be quiescent during the weaning process, and should a patient have an arrhythmia burden, particularly ventricular arrhythmia burden that increases with wean, may denote that it's not successful. Next is laboratory. So beyond the traditional labs that we check multiple times a day in patients who are on temporary MCS, lactate, ideally we'd have a lactate that's over 2. The question came up earlier, what's the first thing that you do when you see the patient in the emergency department? I have always been the person, walk in, hand on the foot, look at them in the eyes, introduce ourselves. And if we get a lactate that's over 2.2, then that right there is a red flag. So definitely serial lactate monitoring. Another interesting point of conversation maybe afterward is, how often are we checking serial lactates during the weaning process and even after we've weaned? Liver function tests, bicarbonate, obviously serum bicarb, and then you want to monitor your arterial blood gases and monitor for improvement in acidosis. And lastly, the art of the physical exam. No amount of AI, ChatGPT is going to tell you how to do a physical examination on a patient. From a neurologic perspective, you will assess mentation, Glasgow Coma Scale, really engagement with the patient delirium to try to understand if that's getting better or worse. From a cardiac perspective, you'll obviously address everything that we've already talked about, but look at the device itself. Look at the console. Don't forget to look at the console. Is a patient requiring, from a respiratory perspective, more or less support to be able to be ventilated? So whether or not they're on the vent, is their oxygen requirement going up or down? Do they have an increase or change in pulmonary edema, both on physical exam and via chest x-ray? Is there a change to respiratory rate? What's the PEEP? From a renal function perspective, obviously urine output, very important. Can't underscore enough accurate urine output in this patient population. And then perfusion. Are they cool and mottled, or is that improving with time? And after assessing all of these factors, when is it appropriate to consider the wean? So as I mentioned before, there are some weaning protocols that have been published in the literature, and the timing to initiate the wean has not been well studied. But there are recommendations to begin weaning once there is resolution of the cardiac dysfunction, improvement in end organ hypoperfusion, stable hemodynamics requiring minimal or stable inotropy, and improvements in ventricular function and size. Once weaning is determined to be suitable, a daily readiness wean strategy has been described with a localized protocol. So if you don't have a protocol, maybe now's the time to be partnering with others in the room and look at protocol that may be in place. Rapid wean occur in states where there was reversibility to the cardiogenic shock state, however longer wean may be needed in heart failure cardiogenic shock. And it's reasonable to use low-dose inotropic or combined inotropic and vasopressor therapy during the wean process. When a wean is not successful, the decision to proceed with cardiac transplantation or durable LVAD or nothing can be considered. Do not forget about durable LVAD. Please don't forget about durable LVAD. We've seen a drastic reduction in durable LVAD implants across the United States, and we know that there's patients that could benefit from this therapy, so please don't forget about it. Transplantation may be considered in patients who are under the age of 70 years old, and that's it. Send them and let us do the rest of the work. Let us do the multidisciplinary evaluation to assess their candidacy. If you are a spoke hospital sending to a hub hospital for consideration to transplant, word to the wise, don't tell the patient that they're getting a transplant, because they may not always get one, but they are going to be considered for a transplant. And we are moving to a hospital that can discuss that with them and really undergo the evaluation. I would say that that's a really important take-home point. And lastly, durable VAD can be considered really in any, I like to say any age, but patients who may not be considered for transplantation. We have really done a nice job of successfully weaning, I don't know where my slides went, but I'm over time. We have successfully weaned patients or bridged patients from temporary MCS to durable VAD strategies who actually are doing quite well now and living the life they want to. So with that, I'd like to say thank you to all the nurses and advanced practice providers who are here. Thank you for the work that you do, and I'd be welcome to take any questions.
That was great. I clapped. Yeah, I clapped really hard. That was great. And just so you know, like the same thing happened to me a couple of years ago. They just shut off my slides. I was like, I can't advance my slides. They said, exactly. I told them very well played. That was a great talk. And I think, again, it drives home this sort of unifying theme is of goals. Goals, goals, goals. It's important for us always to have goals and to reassess those goals as part of a multidisciplinary team. In my opinion, the weaning process is scarier than the escalation process, to be honest with you, because when someone's coming in decompensated or an extremis, your job as an advanced practice provider, as a nurse, as a critical care cardiology physician interventionalist, is to give them as much stuff as they need to reestablish adequate perfusion, reestablish a relatively normal homeostasis, and then hope to get out of the way. But when you wean, again, just about anything can happen, and it's unclear based on what you said what the right goals are. So, how do you do that in the absence of really sort of an evidence base at all? I mean, what do you recommend to your providers who you support administratively and clinically? Like, do you encourage them to develop weaning protocols? Do you or just kind of enter each day or enter each shift with some goals in mind?
It's a really good question. I would say uniformly what I'm hearing across the start of today is that the importance of the teams making the decision together about how they as programs will proceed with the management of the cardiogenic shock patient. Because it's not one nurse making a decision by themselves or one advanced practice provider who feels like this Wean protocol is the best. There really has to be uniformity in an approach on a program level to be able to engage our advanced practice providers, our fellows, the residents, everyone who's coming through. So I'd like to bring back, actually, I think it's really important to bring back, hopefully after this weekend, a more enhanced focus on Wean strategies. I also think it's really important, and this is my opinion, to engage with the advanced heart failure team as early as possible to put patients on the radar. So as Robin mentioned, what you have is really unique in your program, and the robust cardiogenic shock team being involved with any patient that's on percutaneous MCS or temporary MCS, it's not like that everywhere. And so that's a really, I think, best practice that we in this audience need to hear.
This is a perfect, oh, is this on? Can you hear me? Can we turn that mic on? I think it's on now.
Yeah.
Hi, I'm Jessica. I'm a nurse practitioner at Wake Med and close to you.
Hi.
So as you know, we've gotten Dr. Russell, we have Parikh now, and I've actually been tasked with help us create a cardiogenic shock team because this does not exist. And until they came, it was little old us cardiology and patient providers trying to rally the troops and get patients the care that they need. So do you have any tips on how to go about creating a cardiogenic shock team essentially from scratch?
Yeah, good question. I wish Carolyn Rosner was here. She's from Inova. Unfortunately, she wasn't able to make it this weekend. But I would say if there's anyone who knows how to do this well from an administrative perspective, it's Carolyn Rosner at Inova. And one of the lessons that I've learned from them is it doesn't just start within your program. You have to really be thinking about what the community partners are doing to get patients to you. How you operationalize a program in your institution is very individualized based on the resources that you have available, the services that you can provide. I would say that the start of at least establishing a goal of developing a team is a huge step. You're rich with resources. You have a number of dedicated physicians, advanced practice providers, clinical nurse specialists. I can't underscore enough the role of the clinical nurse specialist or educator with developing the programs. And I think it's really, my suggestion would be network while you're here. If there are people in this room who have a great shock program, put your hand up so that we can send them in your direction. There you go. Dr. Wald's volunteered herself after she's, another cup of coffee, I think it might take. But I would say use your resources that are published in the literature and task some of the folks here to help talk you through it further. I don't know that I answered it completely, and I don't know if that...
I think that's perfect advice, actually.
That's why we're here.
Yeah.
Thank
All
you.
right.
Thank you so much.